and see how do we manage patients in pain in ICU. Okay, so these are the outlines of my presentation for this evening. So, okay, I'm just going to go through regarding all this topic, because I think every single one of us has been working ICU, has been managing patient ICU in terms of the management of patient with organ dysfunction, or patient post-operatively, and most patients also may have some degree of pain in ICU. So it's just commonly being managed by us. So for today, I'm just going to sort of put things in perspective, to recapitulate what we have been managing so far, and see that there are maybe a few things that we can do to improve our care of the patient. And we know that all critically ill adult patients in medical, surgical, trauma, intensive care units typically experience pain. Whether we ask or not, actually this patient, a big percentage have some degree of pain, both at rest and under routine ICU care. And these patients, they have the right to receive adequate pain management where required. And I think it's already known that pain is associated with an acute stress response. So patient in pain, anybody, even if we have headache as well, already in distress. So patient in pain will have distress response, and this includes changes in terms of the neurovegetative system activity and the neuroendocrine secretion. So the HPA axis will be affected in patients who have significant pain. They may also have some psychological distress, manifested as agitation. So agitation can be due to many things, and one of them could be due to uncontrolled pain. The Society of Critical Care Medicine, SCCM, recommended to utilize the analgesic sedation, wherein a patient's pain is treated adequately before using sedatives. So meaning that we have to address, it's not just sedation only, not that patient appears restless, okay, we have to give more sedation. We have to see whether it's because of just being restless, anxious, or maybe the restlessness or agitation is due to the underlying pain, which is not well controlled. So the concept of analgesic sedation is there now. Okay, in terms of the causes of pain in ICU, I just want to highlight that we can sort of classify into biological, psychological, and social, the so-called biopsychosocial. So nowadays when we talk about pain, we talk about biopsychosocial. It used to be people talking about biopsychosocial aspects of chronic pain, but now even acute pain as well, or pain in ICU, or pain in critical patient also can present as something which affects all three components of biological, psychological, and social. Okay, so if you see a few other things that are there, so maybe, for example, biological, underlying illness itself causing pain, or surgery or trauma can cause pain. Or it may be due to our intervention. Patient's ICU is never free of devices and tubes and catheters and everything. So they have tubes and catheters and everything poking into them. Those will cause pain. And sometimes when it's attached to the patient, secure the patient, movement will cause tugging on on the tube or catheter, which also can cause pain. And another thing is that even a prolonged immobility. Just imagine yourself lying in bed for the whole night and not allowed to move at all for the next 12 hours. You cannot turn to the side, you cannot roll over, just lay still, not moving for 12 hours. What happened to you the next morning? You'll have muscle ache. So this patient, even though they are with some critical illness, they are not moving in bed. So that itself can cause a lot of musculoskeletal pain to the patient. Okay? In terms of psychological, of course, there are myriads of things that can affect the psyche of the patient who are in distress in ICU. And social, the feeling of being isolated, left by the family, or feeling of giving trouble to the family also may cause some distress patient. And that patient who is in distress can cause increase in pain. They have become more sensitive to pain. So what are the barriers to pain management in the ICU? So we know that there exist multiple barriers to the provision of effective multimodal anesthesia to critical illness. Even patients in the ward also there are barriers, but worse so in ICU. So because ICU, most people, most doctors, most staff put more emphasis on the care of the unstable main organ function, the cardiorespiratory. So less emphasis is being put on the pain management or other parts of care of the patient. So we can classify into patient-related, provider-related, or healthcare-related barriers. Okay? So the patient-related and the provider-related can be addressed in the analgesic management strategies, whereas the healthcare-related barriers, then of course we have to look into the requirement of making a policy for care of the patient. Education, meaning that we need to give the doctor and staff how to recognize patients in pain and how to assess the degree of the pain. And we need to have some workflow for the care of the patient. Okay. So we go, for example, barriers to pain management on patient itself. The problem is that most patients, either they are intubated or they have some devices for airway devices, or they have a face mask or full face mask. Then it's difficult for them to allay or convey the degree of pain to the caregiver. So then they may not be able to give the pain scoring, to report the degree of pain, the intensity of the pain, and with that, if they appear calm, then we may be misled by, okay, this patient is not in pain. So we just look into other aspects of care of the patient. And the differential in reporting to doctors. So some patients, especially when they are ill, they wouldn't know how to explain that they are in pain. And it's difficult to say that where is the site of the severe pain. The patient may have, for example, polytrauma or multiple surgery, so multiple types of surgery. So not all parts will be having some same degree of pain. So it's difficult for patient to convey the message of the severity of pain or the type of pain to us. Or even fear of the consequence. They may think that if they keep on reporting pain, the staff or doctor may think that they are so fussy. So they don't want that to happen to them, so they might as well keep quiet. Okay? So other things, so many things are the barriers that in terms of the patient aspect. Another aspect is that in terms of the provider themselves, the doctors and the nurses, in terms of knowledge deficit. So maybe it's not easy. I think most of you by now has gone through all these assessment, discussion about pain management in the general patient in the ward. But in terms of intensive care, patient critically ill, not able to convey the message. Patient, maybe the facial expression, maybe because we are thinking that it's because of some other things. So the knowledge deficit in terms of assessment of patient will cause some discrepancy in the care of the patient. And pain management, of course, may be assigned as a low priority. People will look into the more important aspect of care of the patient. Patient may have an unstable blood pressure. Patient may be having hypoxia. So emphasis usually is more on the cardiorespiratory, the renal system, rather than asking about pain degree of the patient. And of course, the failure to assess the existence of pain, not acknowledging that this patient may be in pain. So some people, to most people, it's obvious. If they come from OT after surgery, then we know that patient post-op definitely will have pain. But if this patient comes from the ward or following some appears to be a minor trauma, but they may have an internal injury, so we miss the degree of pain of the patient. And so many other things that will cause the barriers to the assessment of the patient in pain. And healthcare system, if there is a lack of accountability of the acknowledging the outcome of care of the patient, or if there is inadequate policies. By now, I hope that most of the hospital in KKM or any other institution, even the universities, hospital as well, by now should have the protocol for pain management. And of course, protocol is nothing, it's just lying in the books, in our papers. It's not being conveyed, explained, and practiced by the doctors and nurses. Okay, now we go into the pain assessment. how do we assess patient in pain? So this is one of the things that I think among one of the delayed assessment of pain in the pain-free program in KKN is in the area of ICU. They started very well in the ward, but ICU, obstetric care, and certain other areas a little bit delayed because, of course, it's not quite straightforward. So assessment of pain in the critical patient is difficult, owing to those barriers as I mentioned earlier. So, however, to make it possible, to make it effective for us to manage patient in pain, we need to have a structured, consistent approach to emergency assessment regardless of the admission and diagnosis. So regardless, there may be some medical cases admitted to ICU, there may be post-op, there may be post-trauma. So this patient, we need to have a structured, consistent approach to assess them, because this patient may not convey the message of pain to us, but if we ask and we assess, we may find out that this patient may be in severe pain. So the Society of Critical Care Medicine, SCCM, the pain, agitation, delirium, immobility, and sleep, they call it PADIS, PADIS guidelines as advocate for self-reporting scales to be used as first line for pain assessment. So meaning that if the patient can interact with us, patient is conscious, patient is alert, even though in ICU, even though they are intubated and not able to talk to us, if we can communicate directly with them, they can tell us that whether they are in pain or not. So the primary assessment is that self-reporting skills is more accurate. But if patient cannot be assessed, cannot tell us, cannot communicate, of course, then we can think about behavioral pain scores for those who cannot give a self-report. Okay, in terms of those responsive patients, okay, so we can, like patients in the ward that we have been practicing so far, we can, in KKN, we have agreed that we use the numerical rating scale, NRS, the 0 to 10 scale. Okay, this is standard for pain assessment. But for unresponsive patients, then I think by now most of you, or should be everyone, every single one of us, has gone through the CPOT or the BPS scoring. Okay. For responsive patients, again, if they can communicate, if they can, patient is not intubated, of course you get the pain score from patient. If patient is able to communicate, they are conscious, they understand, they are not sort of clouding or confused, then of course you can get the pain score. Let the patient tell you what's the pain score like. But if patient is intubated, they cannot talk to you, you can still use the ruler. So the nurses in the ward, the doctors ring around in the ward, can still have the ruler with them and ask the patient, and either you help to point or the patient can point to you, what is the pain score like. This is more accurate. And of course, we have agreed that whatever the patient tells you, the pain score is 2 or 3 or 10, accept it. Okay? If the patient tells the pain score is 30, then you can reject. Pain score is 12, you can reject. Maximum is 10 only. Okay? But of course, we have to see. The more important is the trend, not just a single value, like all your other parameters. Okay, another one is the patient is unresponsive patients. Then we use the CPOT and the behavioral pain score. So this CPOT, the critical care prevention tool, and the behavioral pain score, this has already been validated. Validated, insulated, mechanical ventilated with patients. So by now has been agreed and has been used worldwide. If you go to other countries, one country, Australia, US, UK, they have been using this CPOT for the assessment, which is more accurate and it can be duplicated and can be used for to make research studies compare all the management strategies. Okay, so I'm not going to dwell further into this one. I think by now, if you are not sure, then you need to organize within your own department on how to assess patient in ICU. I'm not going to touch on that. I think we don't have time for that. Just briefly only. Now I'm going into once you already assess patient, you know the pain score of the patient. How do you manage the patient? So management of acute pain in intensive care requires an individual multi-model. Again, the word multi-model. So by now we should get familiar that management of pain is multi-model. It used to be single therapy. It used to be polypharmacy. Now we call multimodal. Polypharmacy means that you just use medication only, various type of medication. But multimodal means that you use not just medication only, you use other techniques as well to try to control the pain of the patient. So again, the SSM practice guidelines provide a framework for this challenging group. So I think practice guideline, I think you can get it everywhere from the internet. By now, every single one of us, anesthetists, or those patients, or anybody who are working, taking care of patient in ECAICC hospital, especially in a critical setting, need to read on practice yourself. If you are not sure, then you discuss among your group. I just want to highlight that it's very important for us to know. Okay? So the use of protocolized analgesia and management is associated with improved analgesia. That's why it's very important to use the standardized protocol, because it has been proven it will improve the analgesia pain control of the patient. It will decrease the duration of medical ventilation. I think by now most of you know that patient post-op, if good pain control, then patient can be mobilized early, they can get off bed early, they can go home early. That is the general care. But in ICU, if you control the pain, then patient has less stress, less disturbance of the HPA axis, less all this stress hormone and everything which is immunosuppressant, then patient will get better earlier, better control of infection, better response to the care of your, and also can get on the ventilator sooner. So length of stay also will be shorter. And the duration and dose of opioid sedative options will be decreased. So if we do it properly, follow protocol, then you can sort of reduce your medication earlier. I've seen patients on infusions of fentanyl, morphine at the same rate for 1 week, weeks, or even a month, which is totally unnecessary. So by now, I just want to highlight that we have to change our mindset. Patients on fentanyl or morphine shouldn't be on the same dose for ages, for 1 month, for 3 months. That is not the right thing. Understand the pathophysiology, what's happening to the patient, the need of the analgesia, then taper down. It's the same thing like patient with severe infection, bang them hard with antibiotic, then once it's under control, de-escalate. It's the same concept. There is infection control, this is pain control. It's the same concept. Patient in severe pain, bang them hard with good analgesic regimen. Once it's under control, de-escalate. Patient may not be on any analgesic in ICU if it's under well control, because we have other medication, other techniques of modality for the pain control. Okay. So, in summary, on that part of principle of recommendation of evidence-based guidelines, the analgesic-based protocol for assessment and management is warranted. Pain should be routinely monitored, not at convenience only, not at per shift, not at the change of guard or per shift only that you monitor. So doesn't mean the patient only have 3 pain scoring per day. It should be continuous, especially it depends on degree of patient immediate post-op, then you have to be more frequent. Patient post-trauma, more frequent. As you get better, then of course we can do less and less. And vital signs alone should not be used for pain assessment. This has been proven to be incorrect. Patient, if you think about acute stress response, of course, acute pain patient will have tachycardia, hypertension. If you go on that, patient ICU have so many other things causing tachycardia and hypertension. So if we base on that, it's totally inaccurate. So we cannot base on vital signs alone to assess pain in patient in ICU. Opioids recommended as the first line in ICU. However, paracetamol, the good of paracetamol should be used as an adjuvant to opioids in pain management. So if, I've always said that if there is no contraindication to the use of PCM, please use. To me, it's not right. If you want to say it's a sin, it's a sin not to use PCM paracetamol in patient who is in pain if there is no contraindication, because it's so simple and has proved to be effective. However, the use of NSAID is conditional because we have so many organ problem, patient with problem in ICU, so be careful with NSAID. ketamine could be used. So consider ketamine in ICU patients. Okay. What about non-pharmacological? Okay. Don't just rely on medication only. There are so many things for the doctor and nurses to look into. For example, positioning of patient. Wrong position also can cause severe pain to the patient. Pressure care, comfortable position of the devices. So many things you have to look into, not just medication only. Correct whatever the inappropriate position of the patient. Okay. And these were agreed by patient and nursing staff as the most effective non-pharmacological, and is meaning that repositioning, talking to patient, comfort of patient, simple massage also can help in terms of reducing the degree of pain to the patient. Now we go into the crux of it, the pharmacological pain management. Of course, we understand that management of acute pain may be difficult in presence of the co-administered sedation. Patient may appear sedated. They may not complain of pain to you, so they appear calm, but it's difficult and it's difficult to assess patient in pain. However, it's important to attempt to monitor both processes. Of course, you look into your sedation score, you look into your pain score as well. So, and you try to mesh it together. This may allow titration of both sedative and analgesic medication separately. So, assess patient regarding sedation, assess regarding pain. That's why the concept of analgo sedation comes together. So, hand in hand. And this will decrease the risk of inappropriate therapies. For example, pushing in more sedation, purging more to a patient who appears agitated, which is due to pain. So if you control the pain, you don't have to sedate the patient that much. So try to look into that aspect. The mainstay of treatment of acute pain in mechanically ventilated patients is still bilateral opioid analgesia. So patient in ICU, the main medication for pain control is still opioid analgesia. Why? It's easily titrable. You can titrate, and being anesthetist, knowing opioid is a must. No anesthetist can pass exam without knowing opioid. So meaning that, and you have been using that since day one in anesthesia. So there is no excuse at all for anesthetist not knowing opioid. Okay. So it's easy because that is the main treatment for patient in ICU. However, multimodal anesthesia should be the goal. So again, not just single therapy only, must be multimodal. And the use of non-opioids as adjuvants to opioids in ICU has additional effects. Okay, I just go through very briefly. I think you know about all this. Whatever I'm talking today is not to all of you. I just want to put in perspective. Maybe the jigsaw puzzle is the same pieces, but it's put in a wrong upside down. So we try to put it in proper perspective only. Okay, PCM is safe, non-opioid analgesic, even for critical ill patient in ICU. IV PCM, every 6 hours ICU, with 2 patients with fever suspected infection did not increase incidence of hepatic dysfunction. Again, be careful. The caveat is that if patient already has significant liver dysfunction, of course, avoid. For me, it would be easy. If I do my IPS round, I look into the transaminase. ALT, specifically ALT and AST, both. I don't bother about ALP. ALP is for something else. More specific for liver, ALT. For me, ALT, 3 figure, 100 above. For me, I don't use PCM. I have so many other choice. But it's up to you. But for me, I won't use PCM if the ALT is triple figure, 100 and above. Double normal to up to 99, then use with discretion and check regularly. Okay, but be careful. In elective post-op patient, the addition of PCM improve analgesia, reduce opioid consumption. In general, if you use non-opioid, for example, PCM or NSAID, it can reduce the requirement of your opioid by 20 to 30%. So you need to give lesser dose of your opioid with the use of other medication. However, be careful, if you use IV PCM, they may cause hypertension, has been reported. If you notice, I think by now you know that PCM is never given as single push bolus, isn't it? It's in the bottle. It must be in diluted form, giving over a few minutes, not fast IV push. Because if you give, it can cause hypertension and patient. So be careful. Not all medication can be given as an IV push, which is the standard practice by the anesthetist. from day one of anesthesia. Okay. Okay, what about NSAID? NSAID, again, we know it's very effective. Again, as mentioned earlier, you can reduce the requirement of opioid by 20-30%, but the use in ICU, be careful because of the multiple organ function the patient has. And NSAID COX-2 inhibitors may cause problem to the patient. However, if a fresh case from OT with prolonged case in OT for fast-moving ICU, post-trauma, and has no complication, by all means, give your IV PCM, give your IV paracoxib, and your opioid on top of that so that you can reduce the amount of opioid needed for the patient. Okay. I think I can eat into Dr. Awiso's time because he has a longer time after this. So he has 2 slots, I have only 1 slot, so I can eat into his slot. I just go briefly, okay. On various medication, opioids. I think probably some people want to know this one as well. Which one is the best choice for ICU patient? Morphine, traditionally first line agent in patient without renal impairment. So if there is moderate to severe impairment, be careful with use of morphine. Why? Accumulation of the active metabolite. Morphine has active metabolites. So in moderate to severe renal impairment can cause accumulation of the active metabolites as drug. So be careful. What about fentanyl? So some people like to use fentanyl in ICU. I think probably more common fentanyl in ICU rather than morphine in our hospital. Is it true? Or is it some other hospital are using more morphine compared to fentanyl? Depends on the hospital. So fentanyl has a short duration of action after single dose due to risk. So be careful. Some people, if they don't understand, okay, they give fentanyl is very effective, but it's very short duration. The high peak effect, and then it goes off very fast because of the redistribution. It's not because of elimination, because of redistribution of the fentanyl into other compartments. So they have very good pain relief, but very short period. However, if you use as an infusion to overcome that, long elimination because of the context half-life half-time of the fentanyl. So if you give an infusion, it can cause very prolonged effect. So long elimination half-life leads to accumulation when given high doses for long periods. That's why if you give fentanyl, you will have to maintain fentanyl 20, 30, 40 mics per hour for 1 week. I don't see any rationale. I don't see any rationale people giving fentanyl 20, 30, 40 mics for 7 days, for 5 days. What's the point? You already saturated. Even air mata pun buat fentanyl. Bagi plate sikit sebab dah pukul 3.45 petang, takut tertidur. So fentanyl saturated the body, reduce it. Even though you reduce the rate, it's still coming out from your other compartment, filling up the main compartment. So reduce it. And remember that 20% increased risk of delirium when used for sedation and pain management compared to morphine. So fentanyl can cause that. Oxycodone, some people are using oxycodone in ICU, being used more in critical care setting nowadays. However, because of lack of evidence to guide its use, so people dare not use it. So you have to know about oxycodone before you start using it. Okay, remifentanil. Some people are using that, but it's not fairly common to be used in ICU. Many use in OT for short duration. Issue is that with your remifentanil, there is a higher incidence of OIH. Very good pain control while on it. Once you off it, they can have OIH, opioid-induced hyperalgesia. There is another issue. So, while on it, then okay, you off it, patient get restless, agitated, and you have to do something else. So that's why it's not commonly used. And in terms of benefit, it's not better compared to the rest of the other opioids. Okay, what about intermittent bolus compared to continuous infusion? Duration of medical ventilation, ICU hospital left and down stay, and observation similar. Whether you give us infusion, you give us intermittent bolus, in terms of those parameters are the same. So there is no benefit of either one. Patients initiated on a continuous infusion of fentanyl experience more delirium than intermittent bolus. So if you want to avoid, you can give infusion for maybe a couple of days, 3 days, then reduce it and just give extra boluses only when needed. Either you stop infusion, just give boluses when needed, or you can just give very low rate only and just purge on the boluses when needed for some increase of rectal pain. Okay. Prolonged effusion, the bottom line there is that cautious opioid weaning should be considered in patients that have received a high cumulative dose of opioid, especially those exposed more than 6 days. So in general, patients exposed to a high dose of opioid by 5 to 6 days, if you stop them or release suddenly, they can have withdrawal effect. Remember, it's not that simply, okay, they are fine, stop it. No, they can become agitated after that because of that withdrawal. Okay, what about alpha agonist? The old one was the clonidine, now we use the desmometamidine. So this one may aid in Azzlan both through management of psychological contributors for acute pain, reduce the delirium, agitation and anxiety, also avoidance of potentially anti-anesthetic influence. The use of midazolam in patient who is in pain may cause patient to appear sedated, but it causes the analgesic effect, cause increase in pain to the patient. Thank you for the... Okay, thank you. Boleh. Doktor besar bagi kebenaran, bukan dia orang bagi kebenaran. Yang angguk. Okay, so however, in terms of benefit, there is no benefit. The long-term benefit of use of desmometamidine is about the same compared to other opioids. So there is no, it's just a perception. Nowadays people talk about perception. So perception of the benefit of desmometamidine, because it's a new drug, nampak macam bergaya sikit, but in terms of overall, it's just about the same. No benefit in terms to compared to others. Okay, ketamine. Coming to ketamine. Ketamine as a potent analgesic anesthetic agent and also bronchodilator, positive effect for the in terms of hemodynamics. In mechanically ventilated patients in ICU, the use of low dose ketamine. We only need to use low dose ketamine. So this one from this journal by Budget and al. Intensive care medicine in 2019 suggested that use of low dose ketamine infusion resulted in a decrease in morphine consumption by 20%. With a decrease in the sedative requirement and when the patient is stable, you didn't have to use high opioid dose, you use ketamine, that will help the patient. But the caveat is that see the line that decrease in morphine consumption is not a substitute to use of morphine. Meaning that patient in ICU or patient in pain, oh okay, we start ketamine. You have not started adequate opioid, which is not appropriate. Ketamine only blocks certain pathway only of the pain pathway. The main pain pathway is still blocked by your opioid. But patient in severe pain, they open up other pathway whereby the pain signal goes in. So you block that one as well. Then patient get better. So do not use ketamine solely. Use ketamine on top of your adequate dose of opioid. So for example, if you see a patient using bigger doses of morphine or opioid than expected, patient post-lobotomy, requirement of morphine up to 3 or 4 mg per hour is still severe pain, then consider your ketamine so that you can cut down back your morphine to the lower dose. Not just starting ketamine and off the morphine, which is not appropriate. Okay. And as for me, I use much more dose. For example, I only use ketamine 5 to 8 mg per hour for adult patient, which is adequate. Give a initial loading bolus of 10 to 20 mg loading bolus and continue at 5 to 8 mg per hour is adequate to control pain for patient if you do it as a multimodal. Okay. Just 2 or 3 slides to finish up. So remember, I think one of the sessions we have the RA. RA is still beneficial for patient, especially if you see that patient with after laparotomy going to ICU, you can still put in catheters, and nowadays people try to shy away from epidural, as mentioned earlier, because of other issues. So you can use more other techniques, newer techniques. For example, rectal sheath block bilaterally with catheter or not, up to you. Or for example, patient with polytrauma and multiple rib fractures, you can do your ESP, single shot, or with catheters, up to you. Those are beneficial, and that one will you don't have to do thoracic epidural for the patient. Okay. Remember, patient for any procedure, please consider pain management patient. Even as simple as suction of EPT. If that causes distress to the patient, they can always give a small dose of your fentanyl. Do not increase the fentanyl rate infusion. Just push before your procedure and maintain low dose of fentanyl only. Okay. In conclusion, pain assessment of patient ICU is very important using the structured and consistent approach. Wrong assessment, wrong management. Okay. So that's why it's very important for you to assess appropriately so that you can get the right management of patient. Use the protocolized anesthesia management. This will help in terms of improve outcome of a patient. And the mainstay of treatment of acute pain in mechanically ventilation ICU is still bilateral anesthesia on top of the multimodal anesthesia, which should still be the goal. Thank you so much. Sorry for the extra time.